Okay, so this is the first lecture on wet AMD. So the incidence of wet AMD is 40,000 per annum in the UK alone. So what are the consequences of this? Well, we see hemorrhage occurring. As a consequence, we get the serous retinal detachment or pigmented epithelial dislocation or detachment. We get exudate deposition. This is predominantly the lipofuscin and protein-rich drusen that accumulates about Bruch's membrane, separating Bruch's from the RPE. We can see that here on the right-hand side. And type 1 is more common than type 2 CNV, but rather than referring to the types, what we're going to do here is refer to the newer classifications, which are classicals and occults. So what's the symptom if you have wet AMD? So you're going to have decreased VAs, obviously, and you're going to have metamorphosia. Now, if you look at the normal vision on the left and the metamorphosia or distortion on the right, you can see that. That's readily apparent in an Amsler grid, which are knocking about the EED, if you ever need them. And sudden onset scotomas, you get a rapid decrease in vision, rapid decrease in VAs, and a rapid onset of those normally central scotomas. And this is obviously different from the dry AMD, where you get minor metamorphosia, gradual decrease of VAs, and a gradual onset of the scotoma. So if there's a big change, it's notable. But if it's more peripheral, or if the patient just genuinely didn't notice it because it's in their less dominant eye or whatever, it might not be picked up unless it's by the opticians, in which case it's an EMAC referral. So the CNV, choroidal neovascularization variants that we're looking at are classical versus occult. So in a sentence, classical refers to things that have a well demarcated membrane versus the occult, which is the opposite. The hyperfluorescence occurs later, is more spotted, and less well marked. That's because the classical lie above the RPE and the occult lies below. So we have the RPE there, sat on Bruch's membrane. In between the two, that's where drusen deposits. The little red bit there represents the classic CNV, so it's supra RPE, and then we have sub RPE for the occult. So what are the warning signs here? So in classical, we get early light hyperfluorescence on the FFA. We get a well demarcated membrane, and it progresses in the mid and later phases to a greater fluorescence. So here's a good, nice color image. Early, mid, and late phases. You can see how it's progressing, becoming increasingly fluorescent, and we have a nice demarcated membrane there. Same here. So what about the occult? Well, we have a late leakage without that characteristic membrane pattern. The detachment sees RP elevation, spotted hyperfluorescence. So you see early on we don't have much, and then later on we get this poorly demarked membrane. Now occult can morph into the classic if the neovascularizations penetrate from subretinal to intraretinal, and then you get the accumulation of the IRF, which is obviously very much more deleterious to sight. Same on there and there. So that's some nice spotting that you see there at about 5.5 minutes as opposed to 53 seconds on the FFA. There we are. So the types of occult CNV that we find. So you got the classic, you got the occult. Remember that the occult is the sub-RPE. Of the types of the occult, you have polypoidal choroidal vasculopathy and retinal angiomatous proliferation. So let's take these in turn. So the definition of PCV, intrachoroidal vascular network terminating in an arteriolar aneurysm. Well, let's unpackage that a bit. So it's within the choroid, it's sub to the RPE, and this vascular network, these blood vessels, will terminate in dilations. That's what an aneurysm is, a dilation of the vessel. Now, many things can cause dilations, such as, thoracic and abdominal aortic aneurysms. So let's look at the pathophysiology of PCV, polypoidal choroidal vasculopathy. So you've got 3 layers of your arteries here. So you've got the lumen, the tunica media, adventitia, and the tunica intima most intimately, obviously. The tunica intima, you see this internal elastic lamina, and then you've got some more elastic fibers about the adventitia. So What I'm trying to get around here is that you get a disruption in the internal elastic lamina. So the innermost layer, that elastic layer, gets disrupted, broken apart, so you're not getting as good a recoil as the blood pulsates through the arteriolar system. You also get a loose association with pericytes, which are supporting cells. A bit like your glial cells in the nervous system. Little pod end things. You see them in the glomerular filtration mechanism as well of the kidneys. But this loose association with the pericytes means that they're not going to keep their integrity and they're going to bulge and dilate. So you're getting these end structures, they're not recoiling, the scaffolding holding them together is not working, and you get a dilation. So let's investigate. You see these orangey nodules, and this is sub-RPE. There we are. The right-hand side is a lovely little one where you can see a little spotted hyperfluorescence there. Because remember, this is an occult membrane, okay? This is occult. So you're going to get that. But in the PCV, that's what you're seeing. And PCV, here's a lovely one. This is taken with ICG, the indocyanine green, which gets the deeper choroidal vessels as opposed to fluorescein, which is a lot more... the more superficial choroidal vessels as opposed to the deeper vessels, which is what fluorescein shows up. This is a good thing of the intraretinal cyst degeneration, so you can see a lovely PDE there, set of PDEs, and also you can see some intraretinal fluid as well appearing. Good Heidelberg image there. So what is RAP? So we've got a type 3 CNV is what it would have been called, whereby you can have intrachoroidal, a bit like PCV, you can have intraretinal, or both at the same time. So you can have neovascularizations occurring not just in the choroid, but also in the intraretinal area. So if we investigate RAP, we see that on fluorescein it's useful early, but then we get a stain, we get a washout, okay, in the later stages 2 and 3. So it's kind of occluding, because you get a big leak over the top, and you can't see any of the later intrachoroidal things. On ICG, we get a little bit clearer because it has a good affinity for fibrin in the cystic spaces in the late phase. So we can pick some of that up. Obviously, you're going to see a lot of the clotting factor fibrin, if you remember your coagulation cascade. The fibrin plug and all of that. So that is picked up with ICG. Lovely little late phase of hyperfluorescence. On OCT, you see these cystic spaces, and this is a good way to differentiate PCV from RAP. So look at the IRF, the intraretinal fluid, as well as the PED, just below it there. So those two things, very indicative of something that could use monoclonal antibody injection of anti-VEGF. And that's a good way to put it. So on the left-hand side, you've got a serous PED, which is avascular, so we wouldn't use anti-VEGF on that, but in the other one it's vascularized, so anti-VEGF could work to antagonize the neovascularization. So you've got the intraretinal fluid as well as the PED. So if we're looking at a clinical study from 2010, angiographic and OCT features of retinal angiomatous proliferation. So what are we seeing on the angiogram? What are we seeing on the OCT of patients with RAP? So I've just lifted a bit from the conclusion. So of the 48 eyes, 19 had IRF alone, the rest had IRF and SRF. So all RAP lesions appear as occult or minimally classical CNVs on FA without clear evidence of PED. So we're not seeing a lot of PEDs, we're seeing quite a bit of IRF and quite a bit of SRF, but in all cases we saw IRF. And in all cases they were occult. So that's what we're seeing in RAP. So RAP staging. So I'll just go very quickly over this. Type 1, you get intraretinal neovascularizations, common edema there. So this is why you're seeing IRF, because even in stage 1, the patient has IRF, because you've got the leaky blood vessels within the retina. In stage 2, intraretinal, subretinal, and preretinal hemorrhages are occurring, and PEDs can be quite common in stage 2. In stage 3, you get a large serous PED, which anastomoses between the two. Anastomosis are the union of vessels. They can be common and useful for collateral circulations. The heart needs more of them, basically. So the treatment that we're looking at for wet AMD is an Amsler grid. Keep an Amsler grid, regularly check that grid. They give calendars that have them on the side, so every time you look at the calendar, just cover one eye, hold it an arm's length away from you, and just see if, when you look at the central point wearing your reading glasses, are any of the lines wavy, basically, one eye at a time. And just counsel on what to look for. Register as being severely visually impaired if you are. Lifestyle changes: don't smoke. It has all the cardiovascular risks associated with it, the increase of reactive oxygen species damaging the tunica intima, which causes, ultimately breakage, but also the aneurysms that are associated with things that we've just been talking about, PCV. And then the carotenoids, all the colourful fruit and vegetables, they reinforce the RPE, which is so essential for the homeostasis and the maintenance of the photoreceptive layer of the neuroretina. It's so essential. So the interventions that we can do on a less conservative nature if we need to, so anti-VEGF, they get those injections that float to the back of the eye, and the anti-VEGF will bind to the VEGF receptors on the blood vessels and prevent future blood vessel growth from occurring. Just look at the top line there, short-term, long-term. If you use the anti-VEGF treatment, you see that there's quite a stabilization, or even arguably a little bit of reduction in the growth over time. Short-term, not so much of a retarding effect, but in the long term, yes. The other way, if you don't give it no treatment at all, more and more and more, a lot more angiogenesis occurring. So PDT, photodynamic therapy, can be used when? So nice. Anti-VEGF monotherapy appears to result in superior visual outcomes alone. There is a however. In patients with PCV, the occult polypoidal choroidal vasculopathy, a combination may be more effective than anti-VEGF alone, which is very relevant to say. So let's look at the Everest study. PDT with the anti-VEGF monologue was superior to just the monotherapy of the anti-VEGF injections in achieving complete polyp regression in PCV in 77.8 cases. So in all of the treatments, in the classical, in RAP, occult, anti-VEGF alone is good enough. So your default is anti-VEGF. And anti-VEGF is pretty good with PCV, but we get superior outcomes to the monotherapy of the injections with PCV. So let's summarize classic versus occult very briefly. So the classic is a clear supra-RPE membrane with early hyperfluorescence, which continues to increase in the fluorescent intensity over time. Occult is mostly sub-RPE. You get a late leak, and PED is associated with the SRF. And they come in two flavors. So your PCV, you have those lovely dilated orange nodules and intrachoroidal neovascularizations, and you have RAP, which is a type 3 CNV. And those anastomose between the intraretinal and subretinal choroidal neovascularization.